Good evening, ladies and gentlemen, and teachers. Sorry, good morning. Okay, this is my presentation topic today: the comparison and assessment of prevalence and associated risk factors for a Helicobacter pylori infection in Nanjing and Rawalpindi, Pakistan. This is the contents of my topic. Firstly, I'll talk about the background, just to know how about the bacteria which I'm talking about. So Warren and Marshall were the first scientists who discovered this bacteria in 1983. The reason I'm doing this research was the global prevalence of this bacteria and this infection is very high. About 4.4 billion people are infected by the HP infection, which counts about 50% as the total population. And I was more concerned about Pakistan and China. So in Asia, it is about 50%, and Pakistan was more prevalent as the underdeveloped countries are having more chances of this infection than the developed countries. Here you can see Pakistan and China, they have about 70 to 80% of this infection prevalence. So I will talk briefly about the bacteria. It is a gram-negative bacteria having tuft of flagella on the one pole only, and it is a microaerophilic bacteria which needs some amount of carbon dioxide to grow. And this is the transmission of this bacteria, how this bacteria transmits. By poor hygiene, family history, if someone is having, there are more chances you can get the infection. And by kissing or sharing the utensils, crowding living conditions, and contaminated food or water resources, they all are the causes of this infection transmission. These are some of the virulence factors which cause this infection to be more lethal, like flagella, urease, some CAG-A and WAC proteins, some enzymes, and some exotoxins, etc. So why we are concerned about this bacteria? Because the chronic inflammatory response leads to gastric carcinoma. So we have to treat the gastric carcinoma because it is also prevailing in the different regions of the country, and especially in China, and also it's a major issue in Pakistan as well. So the significance is, this study I conducted was to declare what is the prevalence and the comparison between the prevalence of the two countries, and which are the risk factors for this disease and the associated diseases related to the gastric conditions and also the other symptoms in China and Pakistan. But also I conducted a little kind of you can say retrospective study in my study. I added that, which is the prevalent genotype in China, why there is eradication failure in China. So the methodology included the cross-sectional study design, in which I collected the data from Pakistan and China simultaneously, and then did the screening tests for screening out the bacteria, and then the analysis was done using SPS 22. The experimental method in Pakistan and China was different. This was a kind of limitation for my study as well, because in China there were advanced technology and I can do more molecular researches with advanced technology. So we did in China was the stool PCR antigen test, but in Pakistan we could not perform PCR on each and every sample. So for that we used UBT. So to compare the two tests, because they are different, so we conducted this study design of 254 patients, in which we did this screening for both, like stool antigen and the UBT, and compared the results. So there were the compliance of 85%. So there is a chance we can compare these two results. In China, we used the samples, and mostly the inhabitants were of Nanjing, and then the stool samples and the questionnaire were taken from the samples from the population, and then after that analysis was done using the PCR analysis and SPSS. But in Pakistan, as I told you before, mostly UBT test was used. This is the questionnaire I used. So this survey included all the age groups, but in my study it was from the 12 to 96 year of age, and the residents must be of China and Pakistan, and the willingness they show about the study. And the person who were not able to give the informed consent or were like incomplete questionnaires were given, so I excluded them. The second part, I used a retrospective study design in which 4399 outpatients from the Nanjing First Medical Hospital were used, and after the screening by UBT, we used culture and RUT to confirm the test, And then we only 3306 patients, the isolates of the H. pylori, they were yielded positive for the culture. And then mass array was used by, the technique was used to do the PCR and genotyping to check the most prevalent genotype in Nanjing. So the results I will show you with the graphs. The more there were no significant difference between the age group and the H. pylori infection, but as you can see, more males were infected by the infection in both nations. The age group in China were more elderly people, while in Pakistan, the young age group, as you can see, were more prevalent. Age was also showing no significant difference with the infection rate. But there were some factors which I will conclude in the end, not with the tables, as you can understand more easily. The baseline characters of the second part of my study, the retrospective one, it showed the gastroscopic results showing more gastritis in the people, and these were the most common genotypes, which I will also conclude later. And here is one more aspect we concluded after the retrospective study, that the regimens of the treatment, the times of treatment we done on the patients, were also directly responsible for the resistance we're developing in the patients for the antibiotics. So now I will conclude, yes, there was a difference between the two nations in the prevalence, and as you can see, in Pakistan, more the patients were seen of the H. pylori infection. So the factors which came out to be as a risk factor for both nations were educational level, intensity of labor, monthly income, tea and raw vegetable consumption, and with the history, we saw chronic gastritis, peptic ulcer, and number of endoscopies were showing the significant values within the both nations. But in China, there were some other factors as well, like a family crowd population, living area, years of smoking, dining out, regular meals, washing hands, and these symptoms as well. So basically, if you can see from the slide, there were more socio-economic factors which were being positive or being the responsible for the infection. While in Pakistan, only other than the both nations' risk factors, only one loss of appetite was the symptom which was common with the H. pylori infection patients. After the regression and logistic regression analysis I done, I found out the education, population T, some symptoms, spouse gastric history disease, raw vegetable consumption, and dining out were also related to as an independent factor to the Chinese population. And in Pakistan, education and tea consumption in both countries I mentioned, but monthly income, number of endoscopy, intensity of labor, and loss of appetite were also seen. The most common genotypes of the infections were clarithromycin, metronidazole, and levofloxacin were the most resistant kind of H. pylori isolated resistance which we found, and multiple mutations were seen in metronidazole and clarithromycin. Lastly, I will conclude, HP eradication was directly related to the antibiotic resistance as already I told you. This is some of my research contribution. Thank you so much.
谢谢。我们也还是只做一个问题啊，给老师。好，那我们就
Okay, thank you for your good presentation. Initially, you told us that there was imbalance in technology when you are analyzing for the H. pylori. So, and in your study, you are looking at the comparative analysis between China and Pakistan. So, if you want to link your prevalence to risk factors, do you think your study can justify the prevalence vis-a-vis the risk factors in the two countries? Because in terms of tools for analyzing in Pakistan, we see already maybe you have an error in the prevalence because you acknowledge that the tools were limiting factor. So there is an error in prevalence. So the prevalence in China and the prevalence in Pakistan already, they are not you cannot compare. So how then will you link the prevalence to the risk factor in comparative to the two countries? And then the risk factors, for instance, education, family population, how can you link them to the prevalence? You see, you just tell us education and then prevalence. So if you are just talking to a layman, how can you link education specifically to the prevalence and maybe something like family population, etc.? Thank you.
Thank you so much for your question. The first question of you is like, how can I compare the two nations and with the different diagnostic methods? For that reason, we concluded another study I told you before that is it possible so we can like compare the two, so we can did the screening simultaneously, UBT and the PCR, so they yielded almost the same results. And because of the lack of technology in Pakistan, as I already stated, that this was the limitation of my study, but this was a prevalent disease, so I had to continue my study as well. So I can justify this with the results of my compliance result, which was 85. It can be compared. And for your second question, that how can I compare the education level and the family population with the disease, because this is a disease of low socioeconomic status people. So the patients having low socioeconomic conditions in their environment, they are more prone to the disease. So this was also proven by my results as well, that in Pakistan it was more prevalent because of the low socioeconomic status of the poor people, but in China it was somehow better because of the economic conditions and the technology as well. Yeah, thank you.
Okay, thank you, Nida.